Well, good morning and good afternoon to those of you in Eastern time zone and Central time zone. My name is John Pigott. I am the Managing Director for Innovaccer for our payer and life sciences business sectors. And I'll be the moderator of this webinar today, webinar titled CMS Rural Trickle-Down Effect. From unleashing interoperability to closing gaps in care. I'm joined today by two panelists. First of all, President and Healthcare Management and Transition Advisory Services and former EVP of CVS Health and Aetna is Fran Soitzman. Welcome, Fran.
Thanks, John.
And secondly, Mike Sutton, Chief Technology Officer at Innovaccer and former CTO at Kaiser Permanente. Welcome, Mike.
Yeah, thank you, JP.
Great. So let me just review the agenda for today. We're really gonna explore several different trends and effects of data challenges and impact of COVID, the evolution of current data collection strategies. We're going to talk about FHIR, the Fast Healthcare Interoperability Resource, and its impact on our ability to do things like closing gaps in care in a new post-COVID kind of scenario. We'll also talk about key points that health plans should consider to begin preparing for a number of compliance deadlines that are coming up. And then we'll wrap up with our Innovaccer's CARES One infrastructure for payers and the healthcare data platform. So that's what we're going to talk about today, and we'll spend the next hour or so exploring these. First of all, as we go through this, a healthcare data discussion isn't complete without the the description of the landscape and the fragmented data world that we live in, where data is really dispersed throughout the healthcare system. As a health provider, you're needing to integrate or access information on multiple different systems, whether it's in the EHR or in the acute care center or labs, or whether you're in a clinic, or even now with telehealth. It's really scattered all over the place. The interesting graphic here on the data problem. We've got so much data that is contextualized and resides in so many different systems. First of all, claims data, various different formats for claims data that are out there, clinical data that resides in the EHR and various different systems, and then there's a whole new world of emerging data regarding telehealth, genomics, lifestyle, social determinants. I want to pause here on this chart and really just explore kind of the trends that are going on, the trends that we see. And I guess I want to start maybe, Fran, with your thoughts about how are health plans looking at this, landscape of data and data challenges and all this emerging data. What is your perspective? What are health plans thinking about?
Well, you've teed it up nicely, JP. I mean, health plans have been wrestling with this for decades, and the challenge has only gotten greater because it's been kind of a piling on scenario, right? With going to ICD-10, but the government's been moving towards encounter data as being sort of the source of truth. So you still have to capture all this data, but what's going to be utilized, whether it's in Medicaid or Medicare Advantage, is encounter data. So plans have a lot of redundancy. And redundancy costs a lot of money to support that kind of infrastructure, because you have to capture certain data for quality reporting, other data for risk adjustment, for example, and that redundancy sort of feels like cross purposes, and we don't retire things, we just add on.
Yeah.
And again, it becomes incredibly costly. And when you have medical loss ratio limitations, it just puts your G&A under more and more pressure.
Very
So
good.
I
Yeah.
sum it up that way.
So
I just like to add to Fran's.
Your perspective here, because you're kind of the data guy as a CIO and CTO. Well, what's your perspective?
Well, I just want to leverage that point Fran made about never retiring anything, because if you look at this picture, it's kind of like, well, is data here a plural or a singular? Well, in fact, there's an entire sphere that goes behind here, because there are multiple. In my experience and in managing healthcare, or for that matter any enterprise, but particularly in healthcare, there are so many applications that have to be stitched together in order to create any sort of coherent data thing. And so that could be, when you look at claims data or clinical data, that could be 100, or in some cases even thousands of applications that are producing that data that needs to be integrated and abstracted. So it's good that we can put them in 3 categories, but it goes very deep, and all the different formats and all the different versionings and all the different archives and those types of things, in order to get information around a patient, requires that level of depth and not just the breadth that we're showing on this slide.
It sort of parallels the universe, JP. It's ever expanding, right?
Yeah, there you go. Good analogy, friend. Good analogy. So there's all this data that's floating around out there, and the challenge is really a data collection one. How do you get a hold of all that data? How do you put it in some sort of a logical or rational form that you can do something with it? And looking at some of these statistics here, I was quite astonished, actually, to when I see something like 75% of clinical data is in the unstructured form. I questioned the definition of unstructured, because I know I come from a background of a lot of EMR related activities and roles and responsibilities, and I know we put tons and tons of data in structured form. That was what the EMRs were all about. I'm curious, Mike or Fran, what your thoughts are about some of these statistics here.
I think I'll go, if you don't mind, Fran, I'll go first. But I think this speaks a little bit to that depth and the complexity in bringing these in. That 75%, it's not unstructured in the terms of computer science unstructured. Many of these are in record formats, but many of them are not. Many of them are PDFs. Many of them are DICOM, or imaging. A lot of the information that's coming in these new formats of like the digital dust and things that we're learning from people, come anecdotally and through texting and other types of unstructured data. But as well, there's a lot of unstructured data in those hundreds or thousands of applications that they're unstructured in the perspective that they don't follow, for example, the FHIR format, which is a structured format. So they could be record level formats, but for an aggregation, for data aggregation, they require there to be rectified and put into a common format and structured. And the other one I'll just add on there, just another a statistic that we're seeing in a lot of our clients, when they say on average a patient or a member has 80 pages of records, that roughly relates to about 800 rows in a database. And when you start looking at these are coming again from those multiple sources, is being able, and they're identified differently in those 800 records, as many as 10, 15 different ways of identification. That also has to be minimized, and all the duplications removed for that. So it kind of goes back to that expanding universe that Fran mentioned. It just keeps expanding.
Yeah. So you know what, some of the examples that in terms of unstructured data that I'm familiar with, are physician notes, for example, that are appended to an electronic medical record, but they're handwritten or in text that's not structured. Another example might be that there might be a page that is a pre-surgical ops checklist of all the things that you need to do to ensure that that your patient is properly prepped for surgery. And that checklist, once it's completed, gets inserted into the medical record too. And it's so now you have a checklist document. And how do you codify that? Fran, do you want to comment maybe on just the the size, the 100 million medical record reviews that are conducted each year? Enormous amount of records, enormous amount of work for people to do, which is a huge cost to the healthcare system.
Well, it's a huge cost, and it's also, I would say, a source of friction between payers and providers. I mean, it can be incredibly disruptive if not done, appropriately and properly. To the extent that this can be done electronically, it's much more efficient and not disruptive. But to the extent that it's still relying on paper files, it's disruptive because you've got multiple payers coming into a physician's office, throughout the year. But it's necessary because you're doing it for gathering information for HEDIS, for STARS, for CAPS, for all different type, maybe some claims audits, medical record reviews. There are many different reasons why those charts need to be reviewed. So it's incredibly disruptive. So it's not just for risk adjustment, as people oftentimes think of. It's for quality, it's for regulatory reasons. So to the extent that this can be done electronically, 100% of the time, it's going to, I think, take out a lot of contention between providers and the payer industry.
Yeah, I think that getting it done 100% of the time is a lofty goal. There's always going to be some kind of on the fringes stuff that are quite unique and different. But I know in a prior life for me, we at Allscripts, I ran the payer and life sciences business there for 6 years, and we really focused. One of our key solutions that we developed and brought to the market was a clinical data exchange application where a health plan could come to us and say, I want my member Joe Smith, I want every encounter from January through June of 2020, and we would go fetch that record and authenticate it and deliver it in usually about a 24-hour period. And we started with HL7 format and CCD format, and then migrated to CCDA, and FHIR now helps us get a little bit more standardized on how we can do that. And I think also will expand the the amount of information that we can deliver electronically. So we keep chipping away at that number, and I'm not sure where it is today in terms of percent to total. But if we could get it to a point where 80% of the volume is delivered electronically, we'd be doing fantastic. And I guess I'll leave it at that. We'll progress a little bit here. So lots of data challenges, lots of data collection challenges, and And now we have COVID-19 that we're battling, which has created a number of other challenges, around how do you do this, and with a population that's now dispersed and all over the place, is not coming in to see the doctor necessarily. So, COVID's driving even a new need for interoperability, because of people are not showing up into practice every day. There's lots of trends towards telehealth services, and how can you do a nice job of closing either quality or coding gaps when you're not sitting in front of the patient. I guess, Fran, what are your thoughts on this, and and the disruptive nature of COVID, and how the health plans in the U.S. are migrating to address that?
It's a double-edged sword. On one hand, I applaud CMS for accelerating the expansion of telemedicine, telehealth services. It ordinarily, it would have been a multi-year, kind of crawl, walk, run phase in of telemedicine. So the pandemic and the fact that physician offices were shutting down all over the country, and people needed an alternative approach to accessing medical services, and telemedicine was the vehicle, and CMS and HHS stepped up. That's the good news. The not so good news is exactly what you just touched on, and that is it has limitations. You can only do so much by phone or by video, and ultimately either those services get postponed, unless they are clearly a medical emergency, in which case the patient's going to go into the ER. But the gaps in care, I think, are going to result in setbacks in terms of some of the important gains that have been made by the industry, by that partnership between providers and the industry, to improve the quality of life of the patient population, because working together, you can see it in the STAR scores. You can across all the Medicare Advantage plans. You can see it in the Medicaid populations. The plans getting on board, again, can only happen if you got the provider community that's embracing it, working together to improve quality outcomes. And it's at that point of care, you're getting them the data. Well, with telemedicine, again, the limitations. So I think it's temporary. We're going to get through this pandemic at some point, in the next 9 to 12 months. But it's a real issue right now. And it's a trade-off. That's how I look at it.
Yeah, and I think in this short period that we really jumped into the deep end of the pool with telehealth, I think consumers of healthcare, patients, have gotten used to the fact that that's such a convenient way to do things. Now you don't necessarily have for an annual well visit, you don't necessarily have to take an entire day off to plan your day, schedule your day, go to the doctor's office, sit for a long time because you're waiting in line, and then do a largely something that could be done via the phone. So I think,
but that's also a watch out. That's a watch out in terms of the trade-off of the convenience and what may not have, that lost opportunity in the office. A service that could have been rendered in the office, there is that gap. So I think it comes down to physician judgment, whether he or she thinks that telemedicine post-pandemic is the right venue for that patient's annual physical.
Right. What I'm just curious. This is a little bit off topic, but I'm just curious, Fran, what your thoughts are on what kind of quality gaps do we think can be closed via a telehealth visit, and what kind can't? Somebody that needs to actually get their hands on their patient and do a check-in, because it seems to me there could be a number of them that do, as long as the physician has the right information in front of them on their patient while they're talking to them.
Well, I would imagine, you know, there would be those that lend themselves just to, you know, the visual inspection, if you will. You know, anything that requires, you know, probing, that's not gonna happen.
Yeah.
You know, so I think it's gonna be fairly limited. And obviously I'm not a clinician, so I think I'm probably, you know, in the ballpark here. It's probably a relatively low percentage of services that would fall into that category.
Yeah, but I mean, there are a number of routine things as well. You know, a diabetic that needs to get an A1C test, and you know, if the doctor can be presented with their information while they're talking, then they can get that ordered, and the person can go get the appropriate tests, et cetera. So I think there'll be some things you can do.
Absolutely, education and
Yeah, yeah. In any event, okay. Well, that was a bit of a tangent, but
I mean,
yeah, interesting topic.
supplement it. Let me just caveat one other point, JP. Supplement it with technology. You know, in other words, if there's a scale, you know, that
Blood pressure monitor.
pressure monitoring.
Yeah,
so
those kind of.
there are some things that could be introduced, provided it's supported with technology. So telemedicine alone, that's where we have to go to telehealth and introduce other pieces of technology that would supplement the examination.
Yeah, and frankly, you know, that addresses all those sort of emerging unstructured data elements, and how FHIR can really help with at least creating a more standard platform, a standardized approach to ingesting that kind of information. So I think we're getting close. You know, we're not going to solve this overnight, but I think technology, to your point, Fran, is going to help. So I think we're at a point right now when where I want to pull up a poll and engage our audience on just a quick question. You know, and so the poll for the audience are, where do you encounter the greatest challenges due to poor data quality? And we're going to open the poll and give you a few minutes to answer the question, but you know, the choices are quality measure reporting, things that we were just talking about, clinical decision support, being able to create a pathway of some sort and present it for a particular disease state, care and disease management programs, you know, population health related, or revenue cycle management, billing and coding issues. So Fran, if you were to take a look at this, what would you say would be one of the, or some of the biggest challenges on this list?
Oh, I would have to say quality measure reporting and care and disease management programs.
Yeah, okay.
1 and 3.
Mike, you know, as a CTO and CIO, you've been in the middle of the, you know, sort of the data crunch with this kind of thing. What do you see from a technical side of the picture in terms of supporting these kinds of challenges?
Yeah, it's funny. I laugh because it's like every single one of those analytic groups, you know, that I work with, all feel there's those problems. And you know, we've probably had equal pressure from every single one of those disciplines you put up there. So, you know, from a infrastructure perspective, a technology perspective, I think they're all feeling the same kind of pain of, you know, finding access to the data, the time it takes to get data to them, and then directly where this question is going is the quality. You know, many times the analysts that are doing this reporting, you know, they'll say they have to spend 70 to 80% of their time actually verifying the veracity of the data because it was given to them in, you know, mixed formats or with missing, you know, fields. And so, but I got it equally from all four of those groups that you have there, because it's the same infrastructure, and so it just never met the what they were looking for in every case.
Right. Okay. Well, thanks for that, Mike. Well, I'll look to our organizers on the poll. Perhaps we've given enough time for the poll. Can we show the results?
I hope I didn't influence the voting.
Yeah, Fran, who's going to win the election?
So I have, yeah, there we go, 79% quality measure. So well, Fran, you're so well respected in the industry. Everybody just went, oh, if he says so. Yeah, but there's a fair amount for care and disease management as well. So interesting. All right. Well, you certainly called it. That's for sure, Fran. Very good. Any other thoughts or observations now that we've seen the results? Nope. Okay. Let's continue on then. We'll go to we're gonna transition a little bit to, you know, kind of a view from the physician's practice side. And, you know, this data here was astonishing to me, that physician practices have spent more than $15.4 billion, and on average per practice 785 hours a year dealing with quality reporting. It's an enormous amount of money. As we said earlier, you know, when you're reviewing or involved in 100 million records a year, that's a lot of time and energy to put on that. Any thoughts or observations before we kind of dive into this? We'll just keep going then. So this really addresses, you know, we're talking about the data collection piece and you know, the 100 million records that are reviewed a year, and really the evolution of that data collection strategy. It started way before this chart. You know, I think kind of from my perspective, I saw back prior to say 2015, you know, that this was old school. This was health plans I used to call parachute people into the practice, and they would spend days, you know, scanning and copying records, and then put them in their folder and hand carry them back to the health plan, and then they give them to the data collection team, data entry team, to hand enter all those records back into the system, which was A, very expensive, B, fraught with errors. We have migrated, you know, and made positive strides, and we've gone through, you know, a number of different evolutions, I'll call it, or steps. From 2015 to 17, you know, we started getting into the electronic exchange. But we didn't have very good forms and formats. We had to deal with lots of messiness with the data. As we progressed into like 17 and 18, we began to get much more structured with HL7 and CCDA formats, which were good, but didn't include everything that we needed. And now, you know, from 2018 to today, you know, we're making progress and moving into the future with a FHIR standard and the ability to pull data real time with complete industry standards and much quicker implementations. So with that as a backdrop, any observations, challenges that you see, Fran, that the health plans have been faced with, and how did they overcome those?
Well, I think we're clearly going in the right direction. That's the obvious, and it's been painful to get there, but thankfully we're in a much better place now than we've ever been. Real time, the ability to get more data real time is critical. It's a very dynamic business. Things happen fast. You have to have the data timely. Everything is measured. There's metrics for everything, whether it's based on a customer requirement or a regulatory requirement. You got to have the data oftentimes to meet those requirements. So, the other thing I would say is that we're shifting more of our focus on the payer side from claims to social determinants. So that's really getting out in front of it. So that's a different kind of data, right? And it's really understanding environments and what's happening in communities that is creating challenges in people's health downstream. And what do we need to do to affect that? So it's a whole different campaign, if you will, that the industry is going after, working with public health officials and providers and obviously the communities to bring about better outcomes. That's not an overnight solution, but it's long overdue that it's getting the attention that it so desperately needs. So that's something that heretofore was not happening. I mean, 10 years ago, nobody was talking about social determinants. And now it's something that everyone is not just talking about it, but they're doing something about it.
Yeah, very, very pertinent. Mike, you've been through all the bloody years of all these stages of evolution. We're kind of now the current state of data exchange is kind of represented on this chart here with all the multiple different systems on the left, all the various different, sort of as a CIO, all your clients, the business resources that use all this data, multiple different data formats, multiple different data exchange gateways that are connecting to a whole plethora of exterior applications. What are your observations as a technology guy in terms of this evolution, and how did you manage through it, and where are we today? And then I think in a future chart, we're going to talk about the impact of FHIR on this picture, but interested in your observations.
So I think one observation, and having only been in healthcare 7 years, much less than the two of you, I think the future is bright for healthcare, because the bad news is we're behind where a lot of the other industries are. That evolution from sending bulk files and ASCII files that required work on both ends, and then you hardly ever got the data right, and it was an incredibly inefficient mechanism to the point of where the records are now formatted. It's EDI type format, necessitated an intermediary. Well, I was in the oil and gas business. We had the same thing there. As in the travel industry, they had that there as well. And all those industries now, including financial, have all adopted these APIs. And so I think there's a real pattern that the healthcare industry can take from all these people, all these industries that have gone before us. And and like Fran mentioned, I mean, I just my hat's off to the CMS of getting those FHIR specs right, because that is what's required. It doesn't have to be 100% right to get started, but let's at least get a common language to do these exchanges. And then I think what we'll see, just like we've seen in these other industries, is we're going to see a lot of efficiencies coming in, at least, you know, in the bowels of the basement where the IT guys are. The amount of effort required to move the data between people who need it and the synchronization of the data are going to provide real efficiencies for the healthcare space. I mean, to me, you know, like structural type changes because of the utter inefficiencies we kind of had, again, with the thousands of systems and hundreds, if not thousands, of data transfers every night.
Yes. Okay. So let's move forward then. You know, and we talk about the FHIR in the context of this interoperability rule, and it really presents us with an opportunity to really drastically reduce some of these data collection costs and processes that we've discussed by enhancing, you know, the breadth of information and the ability to share with partners. You know, it's a modern standard. It offers flexible payloads. It's a universal adapter. All kinds of good things. I call it motherhood and apple pie from a technology standpoint. So this is really, Mike, I'm interested in your comments on this one. This is really how, you know, the industry is looking at a FHIR-enabled data platform for payers now. And again, very similar chart to what we saw as a current state, but now with FHIR technology laid in here. Can you comment on, you know, kind of what you're seeing on this chart and some of the key differentiations between FHIR and the old way and the benefits that we'll see?
Yeah, so this is kind of, you know, we said, you know, we talked about how glorious the APIs are going to be and all this. Now, this is kind of some of the work that needs to get done to do this. And, you know, because as we know, you know, the EMR systems out there today, you know, a lot of those don't have those APIs. You mentioned CCDs. I mean, we're still getting a lot of files and information in that format. And so I think there's a lot of, and when you put together a healthcare data platform to get to that right-hand side, which, you know, we described as a nirvana, is there's a lot of work that's required to get that data prepared and ready to be put in those APIs. There's, you know, there's the pieces of, we have to ensure quality, because now that the APIs are out there, we talked about transparency they provide. Well, it's also going to show transparency with bad data. And so there's going to be some regimen required that maybe in the past we kind of, you know, didn't have to worry about as much, but a regimen around the quality and the speed and the access of that information. So there's going to be some work in that data integration and standardization column that we have there. And then secondly too, and I know for sure that ONC is working on this, and some of the definition is, you know, the nice thing about APIs is they're transparent. Well, the bad news is they're transparent. And so we need to make sure that when we send information to people, we're certain of their identity. We're certain that we have permission, because during the whole discussion on this, you know, privacy is not, you know, is non-negotiable. The security and privacy of this data is as important as ever. Fortunately, APIs have a very good security control mechanism, but we do have to make sure that we follow the right authentication and identification. And then preparing now for APIs is somewhat of a different infrastructure. Before, when we sent files, all you needed was a file server and FTP server. Well, now you need an API gateway. We need to be able to get consent for people. And then we've got the place where we start producing these APIs. And this is pretty much consistent with, you know, what people are providing, what payers are building out today is, you know, from our purview.
Very good. Thanks for that. So we talked earlier about, you know, FHIR's ability to help, you know, drive quality and gap closure. So, you know, this really represents a few opportunities to use FHIR to drive HEDIS reporting efficiencies, both from a provider engagement, gap sharing perspective, to the ability to influence gap closure by presenting opportunities right at the point of care, and then supplemental data collection. Again, you know, when you need additional data to be able to do all that as much as possible electronically, and be collecting, the most current up-to-date data you can, with, a 24-hour or less turnaround time. Today, we're talking days or weeks. And then collaboration, between, member level rules and internal various cross-functional stakeholders. So, Fran, interested in as you see this, these specific focuses on efficiency, are you seeing the same level of focus within the health plans on using this kind of technology to provide them leverage and efficiencies?
Well, I think it's going to be, I think the plans will rally around it, because I think what it ultimately will do will give them the ability to measure progress more efficiently, more timely, so that they can take action, devote more time to affecting the outcomes, right? Because you have a limited time, right? The timeline is non-negotiable, the measurement period. That's prescribed by the government. And so to the extent that you can have a more reliable measurement period, because you got a finer instrument to do the measurement with, that gives you, reliable feedback, you're going to have more time to then affect it, right? To do the the outreaches to your beneficiaries to affect the ultimate outcome within
Yeah,
that.
that is a great observation, Fran, and one I hadn't thought of until now, and that is, if you looked at the workload as being 100%, perhaps, up until now, health plans are taking 75% of that workload is just getting their hands on the data to create the evidence or insights. And then they have such little amount of time to actually do it, do the work. Now we can make this process much more efficient, and they can spend 80% of their time solving the problem and 20% of their time gathering the data to create the insights.
That's right.
Yeah, very good observation. Okay, so so that leads us to, what do we think payers need to do here as they move forward to get prepared to take advantage of this kind of technology to create that leverage that we were just talking about. They need to set up an IT infrastructure for API enablement, as Mike was talking about earlier on the prior chart. They need to implement and maintain secure on-demand information exchange based on standards. They need to enable this seamless data exchange. They need to aggregate and standardize data, especially claims and clinical data at the member level. Participate in trusted exchange networks. Those will come out and enable easy member health data access. That's actually part of that CMS interoperability rule, patient access. So that's just a quick, list. Any thoughts or comments on that, Mike? This is pretty much technology related.
Yeah, and those, just from a general, kind of data effectiveness, or the data network effect, if you'd like to call it that, is, those last 2 points on, working in exchanges and networks. And, I'll go back to my experience in the travel industry. I worked for the cruise lines, and it would be great that we had an API, but if the hotels, the air travel, the car rental agencies, if they didn't participate in the network at all, there never would have been that plus up with the actual customer. I apologize for that noise if you hear it, but so I think it's the same thing in the healthcare space. Is as we go forward, I think there's going to be a lot of kind of business decisions that need to get made. And if we truly, are going to put the patient and the member at the center of all this, I think being able to trust people in that network to be able to share that information, because we all have the common way of protecting it, I think would be really important to truly enable, total advantage for the members, just like, all the consumer industries have done. It's very similar to me in healthcare. What is going to be very important.
JP,
Yep.
I wanted to just, we talked about this earlier today, but I see, this 1,200-page document, final rules. I think the payer-to-payer data exchange is one of the real positives that came out of this. I think this is going to, I don't see any downside. I think it's all positive. It's going to solve some of the, the pain points for providers, for beneficiaries, patient members, and for payers, frankly, by, sharing data from, members that were one payers for a couple of years and now have transitioned to another payer. It just makes good sense. It just makes good common sense to, every payer is saying that they're a member-centric company, but their actions don't necessarily reflect that. And as an industry, we should be in lockstep with that. And this is a great way to support that.
Very good. Well, so we've talked about, the data collection challenges, some of the new standards that are coming out to help us with that, and healthcare data platform to actually run and manage it on, and really run from these current challenges of multiple electronic transaction standards, lack of singular standardization data formats, incompatible systems, lack of care coordination, no single patient identifier, to a compliant and interoperable payer workflow around compliance with regulatory requirements, direct EMR integration, cross-system connectivity, unified patient records. I put all this in the motherhood and apple pie category. It all sounds great, but there's a tremendous amount of technology and workflows and data management capabilities that go behind that in order to make that happen. With that, I want to transition into our second poll of the day, which is, and this time, Fran, we'll try not to predict and affect everybody's vote. But so the question is, how do you classify your understanding and readiness to implement FHIR for quality programs? A, not aware of NCQA plans and relevance of FHIR for HEDIS, somewhat aware. You got a documented strategy and approach to leverage FHIR for quality use cases, or you've even gotten to the point where you're executing pilots around FHIR for HEDIS and STAR measure improvement. We'll give that a couple of minutes to bake a little bit and give people an opportunity to enter their poll input. Mike, any comments with respect to just sort of the overall trends, the evolution to FHIR standards, the evolution to healthcare data platform to manage that, and where we're headed? Any other sort of summarizing comments about that?
Well, I just I took Fran's comment to heart about the regulation being 1,200 pages. I actually didn't know that, but even with 1,200 pages, there's a lot of room for interpretation in, not so much the APIs. I think the structured way that we share data is fairly well defined, which is really required, because you can't, if you're going to do these seamless exchanges, you need to make sure you understand what that data is. But some of the areas of, what is the interpretation and enforcement of data blocking? What is what level of consent and at what level of detail is consent required. There's issues of delegation, and then, past years, people change plans over, over their lifetime. What are the responsibilities of the legacy plans, going back to 2016 to get that data in? And so, I see there's still room for interpretation of a lot of these things. And, as we have customers that we're onboarding with this, we're finding, that different organizations are interpreting them slightly different. And so one of the challenges we have as a provider in this space is how do we stay configurable for each person's particular use case and how they want to manage those things like, consent as an example.
Yeah, very good. Okay, so to our organizers, do we have enough results in to publish the poll? And Mike, I can't see it, so Mike or Fran, if you can see it, maybe just read it off because they haven't.
Sure, I can see it. The first item, not aware of NCQA plans and relevance of FHIR and for HEDIS is the number one voted at 36%. Somewhat aware of NCQA digital measure plans and FHIR use case is number two at 29%. Documented strategy to leverage FHIR for quality use cases is number three at 21%. And executed pilots around FHIR for HEDIS star measures came in at number four at 14%.
Okay, so generally speaking, people are kind of at the starting line. I either just getting started or just being made aware. Any thoughts or reactions to those results?
I think that's pretty consistent. What we're seeing, JP, is the dates are looming, but a lot of folks are kind of getting fired up. It takes a while to get in the bigger plans, get the project set up, get the team going, and like we've mentioned probably many times, is accumulating that data to solve the needs of the requirements of that spec is not an insignificant task. So I can see people are still kind of planning and getting started in these spaces.
Well, in my observation, Mike and Fran, is that this isn't surprising at all because most of the people that I'm talking to at health plans around implementing this interoperability regulation are focused on implementing the interoperability regulation. This is kind of the next step in the next shoe to drop is now that we've implemented this technology, what can we do to use it for other purposes that leverage it outside of just the those four specific CMS rules. And so this is really saying, how do I leverage it for HEDIS data collection? How do I leverage it for STAR and HEDIS measure reporting, that sort of thing. So it's not completely surprising that all the resources right now are getting teed up to implement the regulation. And kind of my perspective, the next step is going to be taking these kinds of steps.
JP, I think it's important to kind of come back to what the guiding principles of this entire initiative, is all sort of predicated on. And I'm going to paraphrase it, but if I look at the legal language of this final rule, what was behind it, it was always HHS's intention that this final rule was intended to move the healthcare ecosystem in the direction of interoperability, to signal the commitment to a vision set out into the 21st Century Cures Act to improve the quality and accessibility of information for Americans to be able to make informed healthcare decisions, including the data about healthcare prices and outcomes, while minimizing reporting burdens on affected healthcare providers and payers, number one. And then number two, the second rule is that is that CMS interoperability and patient access final rule. The heart of the rule is the patient first mindset, supporting the previous rule by giving patients access to their health information when they need it most and in a way they can use it. So, we kind of get lost in all of the technical part of it. I think it's important to bring it back to, what motivates all of this in the first place.
Yeah, very, very, very true statement. And always keep that end prize in mind, because there's lots of messiness along the way to get there. I want to just switch, and as we wrap up, we have just a few minutes left, and talk a little bit about Innovasor's Care as One infrastructure for payers, and then turn it over to Mike Sutton to talk a little bit further about Innovasor's really platform for the CMS regulatory interoperability rules. So fundamentally, Innovasor is a data platform, data management platform that in our DNA we interface with and ingest data from all those disparate systems that we talked about in the healthcare ecosystem, in the community. We put it through our data activation platform, many different levels of transformation into a unified data model, and create a unified patient record in the community. And then on top of that, fundamental building block architecture are a number of different line of business applications. Provider engagement applications, where we are embedded in the workflow of an EMR. We've integrated with almost every single EMR in the market. We have a care management workflows and utilization management workflows. We have an entire suite of member engagement contact modalities and tightly integrated with our care management system. We've got interactive dashboards and analytics that all take all that data and illuminate, create insights for it. And then specifically the interoperability and regulatory APIs that are specifically targeted at this CMS solution. So at a high level, this is what innovation does for payers in the industry. And then I'll ask Mike to just comment briefly about our healthcare data platform and how it's playing into the regulation. Mike?
Well, and the briefly part, of course, is my challenge, JP. But I mean, fortunately for us, and you showed an API on the last slide, is that our platform has been built, as we mentioned, API has been around for quite a while. So the two good things is our entire infrastructure and application lifecycle is built on a set of APIs. And the other fortunate part is that FHIR spec has been out for nearly 4 years. So there were a lot of drafts. So we were building those out while it was still in draft. Unfortunately, it was implemented, recently as it was regulated. But if you take a look at this is kind of the basic pieces needed. We mentioned many parts of this to satisfy the CMS requirement in our understanding, with the connectivity pieces, creating the APIs, and also making sure that your data is of high quality and that you see member authentication on there, that we're 100% certain that you're giving the data to the right people. And then, of course, now the new things that come out in the regulation is the working with and providing data to third-party apps, and then member consent. And I'll stop there, but this is the basic framework for a solution to satisfy that requirement, and what we're producing at Innovator.
Well, thanks for that, Mike. And I think we're pretty much at time now. So I'm not sure we really have any time left for questions, but any questions that were submitted, we will certainly follow up and provide answers to those folks that submitted them. I just want to take the last few seconds of our time to thank my panelists, Mike Sutton and Fran Soitzman. Thanks so much for taking the time today. Really appreciate it, and look forward to continuing our journey here. That's it for the day. Appreciate your participation of the audience.
Thanks, JP. Thanks, Fran.
Thanks, Mike.